Alaikum. Good morning, everybody. I'd like to thank the organizing committee for invitation. I have no financial disclosure or conflict of interest. These are my learning objectives. So inflammatory arthritis, actually, it's a group of arthritis that are combined by joint pain, swelling, warm tenderness, morning stiffness, and early morning stiffness, which is more than 1 hour. Most of inflammatory forms of arthritis are systemic. So most of them, they have like skin manifestation, eye manifestation, hair loss, mouth ulcer, and fever. The incidence is about 80 to 100 adults per 100,000 that developed inflammatory arthritis every year. And the incidence is ranging from 115 to 270 per 100,000. Incidence of undifferentiated connective tissue disease. From these undifferentiated arthritis, around 10 to 50, they developed rheumatoid arthritis, and the remaining, like 20 to 80, they remained undifferentiated arthritis. These are two important definitions, arthralgia and arthritis. So arthralgia, it means joint pain, while arthritis, it means inflammation of the joint that usually are combined by pain, swelling, stiffness, and usually the most common cause is either infection, trauma, degenerative, metabolic, and other possible causes. So how do patients with inflammatory arthritis present? Most inflammatory arthritis can be classified depending on the history and physical examination. So it's very important to ask about duration and onset, number of joint involved, distribution of joint involved, the present and the duration of morning stiffness, present of joint swelling, extra-articular manifestation, and other associated medical condition. Past medical is very important, surgical, drug history, and family history as well. So the onset is either sudden, abrupt, like in a trauma, gout, pseudo-gout, or infection, gradual or insidious, like in rheumatoid arthritis, or ankylosing, or even osteoarthritis. Duration, acute less than 6 weeks, chronic more than 6 weeks. Arthritis is divided into monoarthritis, which is affecting only one joint, oligoarthritis affecting 2 to 4 joints, polyarthritis, which is affecting 5 joints or more. The crucial first step toward further diagnosis and management, first, are we dealing with inflammatory arthritis or we are dealing with non-inflammatory arthritis? And the second important, are we dealing with articular or periarticular? So to differentiate inflammatory from non-inflammatory, usually the pain is in the morning in inflammatory, while non-inflammatory is usually at the late of the day. Usually we have soft tissue swelling on inflammatory, while it's a bony prominent in non-inflammatory. Erythema most of the time in inflammatory, while it's absent in non-inflammatory. It's more of warm, no warm. Morning stiffness is significant, so 30 minutes and above in an inflammatory, while non-inflammatory, not significantly, usually it's less than 30 minutes. What about inflammatory markers? So ESR and CRP, most of the time it's high in inflammatory, while it's normal in non-inflammatory. Synovial fluid analysis, the white blood cell will be more than 2,000 in an inflammatory, while it's less than that in non-inflammatory. What about articular versus periarticular, which is very important because most of patients come to you in the clinic and say, we have joint pain, and then when you ask them to point the site, they will point another site, so it's not a true joint. So it's very important to differentiate between the two. Articular, it's usually affecting the synovium, cartilage, and capsule, while periarticular, tendon, bursa, ligament. Usually the pain is deep and diffuse in articular, while it's pinpoint or focal in periarticular. And usually in the articular, it's having pain on active and passive movement, while on periarticular during active only. And swelling is very common in articular. Differential diagnosis. So our osteoarthritis is one of first presentation, or I mean a common presentation. either primary, secondary, or erosive osteoarthritis. It could be metabolic or endocrine cause like acromegaly, hyperpara, or hemochromatosis. Inflammatory RA, rheumatoid arthritis, or we have the seronegative group, which is like ankylosing spondylitis, psoriatic, reactive, or enteropathic, or other connective tissue disease like lupus, Sjogren, myopathy, or even systemic sclerosis. Crystal-induced like gout or pseudo-gout, infection, whatever the cause, bacterial or viral. This is the commonest form of inflammatory arthritis, rheumatoid arthritis, which is a chronic systemic disease primarily affecting the joint. Usually it's polyarticular, marked with inflammation of the synovium, and with later stage it may cause deformity and ankylosing if not treated. The incidence is about 40 per 100,000. So usually they have, initially they have risk factors as a genetic predisposition or family history. Smoking is one for risk factor. And then they have the preclinical presentation, which is early, symptomatic, asymptomatic. Sometimes we call it undifferentiated arthritis, and then you have the full-blown of the disease. This is just to compare between rheumatoid arthritis and osteoarthritis. So usually it does not affect the DIP. So rheumatoid arthritis does not affect DIP, while osteo affect DIP, and they have nodules like Heberden. It's asymmetrical, while in rheumatoid it's symmetrical. And you have to look for extra-articular manifestation as well. The second commonest type of inflammatory arthritis is the crystal-induced, either gout or pseudo-gout. I'll not go further because Dr. Khawla will present it later. Osteoarthritis, it's non-inflammatory, but sometimes it misleads you with rheumatoid arthritis, so you have to pay attention that this type of osteoarthritis, where is the involvement, and then to look for any erosive or sign of synovitis. Seronegative spondyloarthropathy, it's a group of disease having IBD-related arthritis, reactive arthritis, psoriatic arthritis, undifferentiated seronegative, and even juvenile idiopathic seronegative arthritis. It's usually associated with HLA-B27. It causes asymmetrical, sometimes oligo, to polyarthritis. 40% of these patients, they have axial involvement, dactylitis, enthesitis, and they have extra-articular manifestation as rashes, nail involvement, or even eye manifestation. Lupus, around 90% of lupus, they present with arthralgia, and they present as well with arthritis. And the particular of it, it's non-erosive arthritis, so to compare differentiate between it and between rheumatoid arthritis. Other features that support lupus is mallar rash, photosensitivity, alopecia, and oral ulceration. This diagram, just to summarize the difference between the four differential diagnoses that I mentioned. What about extra-articular manifestation? We have constitutional symptoms as fever. So whenever you have fever, you have to rule out septic arthritis, disseminated gonococcal, and then you think of other diseases like rheumatoid or lupus or others. A skin lesion, which I will elaborate more in the coming slide. Ocular symptoms is very important. So episcleritis, scleritis is more common in rheumatoid arthritis, anterior uveitis and ankylosing spondylitis, iridocyclitis in juvenile rheumatoid arthritis, conjunctivitis, which is common in reactive arthritis. So this is showing erythematous maculopapular rash, which you could see it in Kawasaki disease, Still disease, or sometimes a drug reaction, urticaria in lupus, hypocoprolitemic urticarial vasculitis, or Still disease. This is a palpable purpura. So you could see it in ANCA-associated vasculitis, lupus, hypersensitivity vascular, cryo, or even Henoch-Schlein purpura. This shows a papulosequamous lesion, which is common in psoriasis, reactive, discoid. Annular lesion, which is common in subacute cutaneous lupus or acute rheumatic fever. Subcutaneous nodule, it goes with erythema nodosum, sarcoidosis, inflammatory bowel disease, Behçet, lupus, and polyarthritis nodosa. And the last one is pustule, which goes with disseminated gonococcal, pustular psoriasis, reactive arthritis, Behçet, or sweat syndrome. Family history. So positive family history of a first-degree relative, it gives a more increased likelihood to develop any type of autoimmune disease. So the risk of ankylosing spondylitis in children or siblings is more higher, like 75-fold higher than the normal population, while in lupus also it goes to 20 to 30 times, and a positive family history of rheumatoid having more likelihood to develop rheumatoid arthritis. So how is inflammatory arthritis diagnosed? This is very important. So laboratory tests cannot substitute for a clinical evaluation and should never be used as a screening of disease. So never ever request an autoimmune profile just as a screening. You have to correlate first, take a good history, do good physical examination, put a MORD, or let's say a good differential diagnosis, and then target your blood work according to your differential diagnosis. So hence the positive predictive value of many rheumatological disease is very low when tests these are ordered indiscriminately. So we'll start with the investigation. Inflammatory markers as ESR and CRP, rheumatoid factor. Keep in mind that normal or negative result does not exclude inflammatory arthritis or even rheumatoid, as around third of the patient, they may have seronegative, like we call it seronegative rheumatoid arthritis, or even negative and seronegative spondyloarthropathy. Doing a CBC is very important, renal function, liver function, requesting other autoimmune profile as directed according to your differential diagnosis, and doing erythrocentesis if it's indicated. What about imaging? So imaging technique is not routinely recommended before a referral to a rheumatologist. And even if you need to do hand x-rays and a feet x-rays, looking for erosion. What about other joints? So other joints is not indicated to do unless there is really a concern to do the x-ray. This x-ray actually, it's showing severe destruction of the PIPs and the DIPs. This is an osteoarthritis patient. While this patient is having almost a fusion of the PIPs and penicillin cup, this is in psoriatic arthritis. So when to refer to a rheumatologist? So refer patient to a specialist immediately if there are a clinical feature of potential inflammatory arthritis. Avoid prescribing a steroid before referral, because the diagnosis can be confirmed, before diagnosis be confirmed, because steroid could mask the arthritis before the rheumatologist could evaluate. So when to refer? So if you diagnose or you suspect any type of inflammatory arthritis as rheumatoid, lupus, psoriasis, and you need to confirm diagnosis, refer to a rheumatologist. Or you find this patient is inflammatory arthritis, but it's undifferentiated and you need to do further management, you need to refer. Or patient having arthritis plus unexplained symptoms as fever, abnormal inflammatory markers, or unexplained other symptoms like fatigue, malaise, and anemia. In management, actually, there was a systemic review of almost 92 studies support that early treatment of inflammatory arthritis with disease-modifying antirheumatic drugs help to improve the function, reduce disability and long-term joint damage. And you should refer with the window 3 months. They call it window of opportunity. Also, other systemic reviews showed that early treatment, control disease, induce remission, protect against morbidity and mortality, especially from cardiovascular. So bridging treatment until remission. So being a family physician or internal medicine physician, you need to help the patient to relieve his pain with giving him analgesia, good analgesia with non-steroidal anti-inflammatory as much as possible. Try to avoid the steroid before he approached the rheumatologist. Rheumatologists usually they give either intra-articular, intramuscular, or intravenous steroid. DMARD, it should be initiated by a rheumatologist, and the recommendation, early referral, early treatment to prevent of more of destruction. What about the prognosis? So prognosis, it depends actually on the cause of the arthritis. If it treated early and appropriately, acute inflammatory arthritis such as septic arthritis or a crystal-induced, it has an excellent prognosis. While delay or misdiagnosis of other inflammatory arthritis, it causes erosion, permanent damage, and it is more of progressive disease. In case of patient with rheumatoid arthritis, seronegative, early and aggressive treatment prevent complication and deformities. So take-home messages. Consider inflammatory arthritis in anyone with acute or subacute onset of joint pain, morning stiffness, soft tissue swelling. Early diagnosis and treatment with DMARDs and steroid improve the function and symptomatic and radiographic outcome. Patient need rapid access to rheumatologist during the flare-up. Prescription and monitoring of DMARD can be shared between the specialist and non-specialist in a clear pathway. Distinguishing inflammatory from inflammatory arthritis, however, it's not always a straightforward process. Combination of high burden of musculoskeletal with the population. And the last, laboratory test cannot substitute for clinical evaluation and should never be used as a screening for disease. Thank you.